So the disease-modifying therapies, which have been available for about 20 years now, offer a variety of options for patients with now 10 FDA-approved medications. And when you start them and when you stop them is very variable depending upon the patient. A lot of that will have to do with the age, their burden of disease, what their MRI scans look like, what's going on with regard to pregnancy plans, insurance issues, and a variety of other things. But I think it's probably fair to say that the majority of people who are diagnosed as your typical young, say 30, 35-year-old woman, perhaps who's already had all their childbearing completed, the vast majority of those patients should likely go on to a disease-modifying therapy as soon as they've been diagnosed with MS, or perhaps more importantly, when they're at risk of having new disease activity that would be manifested clinically as a new problem such as numbness, tingling, weakness, or a visual problem. And that's the way we really think about it. And that would have to do with, for example, some patients who have perhaps only had a single attack of MS. Maybe they do or do not fulfill all the diagnostic criteria, what we refer to as clinically isolated syndrome. If they have a significant increased risk of having new disease activity, the vast majority of those patients likely should go on to a disease-modifying therapy. It becomes a little bit more challenging as patients are perhaps diagnosed in their middle ages, perhaps with so-called progressive MS. Many of the studies have shown that progressive MS patients unfortunately don't necessarily respond to these medications as well as they do if they're younger and have a relapsing form of the disease. But a number of those same studies have shown that relatively younger patients, perhaps under the age of 50, those who have superimposed relapses on top of their slow progression, and those patients who have active MRI scans or after the injection of contrast material, you can see leakage of the dye into the brain or the spine. Those patients may also benefit. So it's not such a simple matter as saying someone has relapsing MS or progressive MS. It's really defining when they have a risk of new inflammatory disease activity that these medicines will potentially help. And that's an important part also when we think about the possibility of discontinuing a disease-modifying therapy. We spend a lot of time trying to determine when someone might benefit from these medications, but we spend very little time, unfortunately, trying to figure out when it would be potentially no longer beneficial, or perhaps the risks outweigh the benefits of using the medications. We know that as people age, they tend to have less new inflammatory disease activity as manifested by relapses and new scan changes. And all the medicines are primarily anti-inflammatory. So at least philosophically or theoretically, we could think that perhaps at some point someone may no longer really benefit from these medications, or conversely may also have increasing risks over time, as we might see with natalizumab, where perhaps prolonged use might be associated with a greater risk of one of the complications of that, the brain infection, PML. So we need to spend a little bit more time on when to consider a discontinuation trial in a patient. And some of the principles that might be relevant would include age. We certainly see less new inflammatory events as people age, and certainly disease burden. If someone has had a relatively modest disease burden over time and hasn't had an acute attack for a prolonged period of time, or an acute change on their scan for a prolonged period of time, perhaps that person, maybe in their late 50s, early 60s, might be a candidate for a discontinuation trial. And when we say trial, we mean a trial. That is, we would monitor that patient closely, we would continue to scan their brains and or spines over time, and we would see how they're feeling. Perhaps they feel better going off of their disease-modifying therapy, but also perhaps they may feel worse. We know that, for example, with natalizumab, quite a few people may feel worse when they go off of their disease-modifying therapy. So we would have to weigh not just what we can measure, relapses and brain scan changes, but also how does the patient feel? Do they feel better? Do they feel worse? How do they feel about risk? Are they scared about going off a disease-modifying therapy? Quite a few patients are. So all of those things have to be discussed, and we have to try and make a plan. But the real answer is we don't have a lot of data yet on when it is reasonable to consider a discontinuation trial.